All right, let's get started. Ran rounds today, very important subject. Implicit bias in medicine. And presented is Dr. Nicole Jones. Nicole is one of our chief residents, and this is the topic that we selected. So, Nicole.
Thank you, Dr. Bocchini. So if y'all could take a second, there are going to be some audience response questions in this presentation. So if you could just take a second to log on, and I'll bring this link up a little later as well. But like you said, today we're going to be discussing implicit bias in medicine. I have nothing to disclose, and our objectives today are define implicit bias, explore the effects of implicit bias in medicine and healthcare, and to discuss ways to decrease implicit bias in the medical community. So we're going to kind of start with a little warm-up activity.
This is a test of selective attention. Count how many times the players wearing white pass the basketball. How many passes did you count? The correct answer is 15 passes. But did you see the gorilla? This video is from research by Daniel Simons and Christopher Chabris.
So initially when I saw this, I saw the gorilla, but I didn't realize how much the gorilla did because I was so focused on the passes. But I think this video does a great job of showing us the unconscious ways that our brain works, and we can be so focused on one thing that we might totally miss something else that's going on, and essentially we can be blind to our own blindness, and implicit bias works the same way. So we're going to do another little audience response, so if you can take the time to either text or log in on the internet. So which one do you feel or think is more dangerous? Okay. So y'all did a good job. So in this case, we have two hurricanes. Hurricane Bertha was a Category 3 storm, and Hurricane Earl was a Category 2 storm. And you might assume that they're equally dangerous. After all, there's not much information here besides the hurricane's name, but there kind of lies the bias. Some people will actually pick Hurricane Earl because studies have shown if you remove extreme cases like Hurricane Katrina, that people often associate male hurricane names as more intense or more likely to evacuate versus female hurricane names are less intense, so people are less likely to evacuate. So there's sometimes a little gender bias at play. Okay. So now we'll do just a clinical encounter. So we have a 17-year-old African-American male patient who presents to the clinic with intractable pain. The patient was recently discharged from the hospital following surgery for a complex shoulder fracture, which he sustained while sitting in a stationary car when a drive-by shooting occurred in his neighborhood. The orthopedic surgeons evaluated him the day before and scheduled a second surgery, but did not adequately treat his pain. The inpatient nurse told him he would be discharged with oral pain regimen he had been taking for the past day or so within the hospital. Upon discharge, he found himself without those prescriptions and came to your clinic in severe pain. Upon review of his inpatient record to determine the reason for his discrepancy, you discover the phrase drug seeking in the record. The rationale for this statement was not provided, nor the context. You question the patient regarding this issue, and the patient is shocked and unable to recollect what he may have said to result in that assumption. He had no prior history of documented substance or prescription drug abuse. So once again, which treatment option is the best course? And I might have to activate this one. Sorry, guys. And so now you should be able to respond. Very good. So if you take everything else out, you have a 17-year-old male, complex shoulder fracture requiring 2 surgical interventions, and he has intractable pain. So the standard of practice in this type of case involves long-acting opioid medication with gradual adjustments of a medication regimen tailored to meet the needs of the patient. However, in this real-life scenario that I found online, this patient actually didn't receive the standard of care, and naturally we wonder why this might have happened. And so the answer may be implicit bias. So I'm going to take a second to define implicit bias, and this is a definition provided by The Ohio State University for the Kirwan Institute for Study of Race and Ethnicity, and it refers to implicit bias as the attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. These biases, which encompass both favorable and unfavorable assessments, are activated involuntarily and without an individual's awareness or intentional control. So even though we might not outwardly be biased, there are implicit biases that we may have absorbed unconsciously that color the way we think, even though we might not even know that they're going on. So implicit bias is not just limited to race, but it can exist for gender, age, sexual orientation, gender identity, disability status, physical appearance, such as obesity, and implicit biases are harbored in our subconscious, not our conscious, but our subconscious, and not necessarily align with our declared beliefs or even reflect stances that we might explicitly endorse. Generally, research has shown that people tend to hold implicit biases that favor their own in-group, but that's not to say that people don't also hold implicit biases against their in-group as well. So with all that said, implicit biases are malleable, and becoming more aware that we unconsciously make some of these associations, we can start to make changes, which we'll discuss a little later in the presentation. So where does our implicit bias originate? So the great debate, nature versus nurture, our genetics determining our behavior versus our environment, our upbringing, and life experiences determining our behavior. And surprise, surprise, it's a combination of both. Our implicit bias are due to a combination of both genetics and environmental conditioning. So since we all already know this, let's take it a step further and discuss how these biases may affect medical decision-making and perpetuate healthcare disparities. So this is a study. So prior to this study performed in 2007, studies documenting racial and ethnic disparities in healthcare frequently implicate physicians' unconscious biases. However, up to this point in time, no study to date had measured physicians' unconscious racial bias to test whether this affects physician clinical decision-making. So as you can see from the authors of this study, this is a very diverse group of people. You have physicians, psychologists, individuals with MPHs coming together to test whether physicians show implicit race bias and whether the magnitude of such bias predicts thrombolysis recommendations for Black and white patients with acute coronary syndromes. So kind of the study design, so they used an internet-based tool comprising of a clinical vignette about a patient presenting to the emergency department with an acute coronary syndrome and no evident absolute contraindications to thrombolysis. And they also didn't have primary angioplasty as an option. They then followed this by a questionnaire and 3 implicit association tests, which I'll refer to as IATs, that we'll talk about in a second. So the study ultimately invited 776 internal medicine and emergency medicine residents from 4 centers in Atlanta and Boston. And of these 776 patients, 393 completed the randomized vignette questionnaire and explicit bias section of the study, but 25 were excluded due to the fact that they were not residents in an eligible program or had previously completed part of the study. 81 were excluded due to failure to complete various portions of the study, and then 67, and I want you to remember this 67, they reported some awareness of what the study was about through the discussion with colleagues who had completed it. So ultimately, we were left with 220 participants that completed the study and were unaware of the nature of the study. So these participants were then randomized to either a Black vignette or a white vignette based on a patient who was around 50 years of age with neutral facial expressions and attractiveness. So this is kind of an IAT. So a lot of the research out there is using IATs to determine or kind of measure implicit bias. So to me, when I first learned about it, it was like a more advanced of the more advanced process or version of the DAW test. So that was performed back in the 1940s and again in 2009 with Anderson Cooper, where they had children of various races. They were asked to associate negative and positive words to a doll, either a brown doll or a white doll, and a lot of times the negative words were associated with the brown doll and the positive words were associated with the white doll, leading to what is classified as a pro-white implicit bias. So here we have some examples of IAT screens. And these screens are from the race preference section of the IAT that was done in this study. So we have A, B, C, and D that represent examples of pairing tasks that the participants were rapidly supposed to complete. So basically you get a stimuli in the center, and you need to either match the stimuli with black patient or bad, white patient or good, by pressing E or I on your keyboard. So in this case, the black face in the center is the stimuli, and you would press E to match it with the black patient bad. And this screen, we have the word pleasure, which we associate with good. So you would hit I on your keyboard and associate with white patient or good. And so you'll do a series of screens with these different associations. And then they do another set where they completely flip it. So white patient is now associated with bad, and black patient is now associated with good. You're given the black face once again as the stimuli in the center. Instead of hitting E as you did up here, you're now prompted to hit I. And then the same thing with pleasure. It's now good and associated with black, so you're supposed to hit I. So basically, what this ultimately does is it measures kind of your response or your speed to associate black with bad and white with good in the screens A and B, and then relative to the opposite pairing of black with good and white with bad in screens C and D, and this constitutes an IAT score. And then it's interpreted to be a measure of implicit race preference. And with that said, the shorter response times for white with good and black with bad compared with white with bad and black with good reflects a pro-white implicit bias, but the inverse can also be said as well. So these IATs basically operationalize unconscious bias by hypothesizing that subjects will match a group representative to an attribute more quickly if they connect these factors in their mind, regardless of their awareness that the connection's being made. So IATs measure the aggregate time required for these matching tasks, and typically subjects are aware they are making these connections, but unable to control them given the rapid response time and structure of the test. So the main outcomes from this study, or the main outcome measures, were the implicit bias association test scores measuring physicians' implicit race preference and perceptions of cooperativeness. And then they had the physician's attribution of symptoms to coronary artery disease from the vignette patients with randomly assigned race and their decisions about thrombolysis. And then they had the section on assessment of physicians' explicit racial bias via questionnaire. So here are the results. So here we have the results for the explicit or the questionnaire portion compared to the implicit section with the IAT test that I showed you before. So due to the explicit and implicit being kind of on different scales, so these measures of an explicit bias and implicit bias, the magnitude of physician's bias across these 7 measures could only be directly compared by converting them all to a same metric known as a Cohen's effect D, Cohen's effect size D. So this is defined as the magnitude of an effect independent of sample size, and it's often used in research and meta-analysis in behavioral sciences. So this Cohen's effect size D of 0.2 is considered a small effect, and Cohen's effect size D of 0.8 is considered a large effect. So if we look at the questionnaires, all of them are well below 0.2, so they have a small effect score. And so with that said, people aren't, based on the questionnaires, aren't explicitly biased. But when you look at the IAT results, you can see a lot of these have a 0.8 roundabout higher, so a large Cohen effect size D score, implicating that there is some bias at play. So when they kind of grouped it for these 3 categories here, starting with the attitude IAT with good versus bad, it showed that here we have the black patients with the dotted line and the white patients here with the solid line. So as physicians implicit bias increased, they were more likely to prescribe thrombolysis for the white patient and less likely to prescribe thrombolysis for the black patient, which was statistically significant with a p-value of 0.009. Now, there wasn't statistically significant evidence when you looked at general cooperativeness and medical cooperativeness alone, but in D here, we combine all of these into one sample, and once again, you see that relationship, whereas implicit bias increased, physicians were more likely to prescribe thrombolysis to the white patient and less likely to prescribe it to the black patient with a p-value of 0.04. So ultimately, as implicit bias measured by the IATs increased, the likelihood of recommending thrombolysis to the black patients decreased, even though these were the same case vignettes and the only thing different was race. So here, remember I told you about those 67 participants that were actually aware of the study's purpose about implicit bias. They actually added them back in, and results showed that as these physicians who were aware their implicit bias increased, they were actually more likely to prescribe thrombolysis to black patients compared to the unaware physicians because they knew that this implicit bias was being tested, and so it ultimately caused them to change their clinical decision-making to meet the standard of care in this scenario. So what can we conclude from this study? So, as I said, this study represents some of the first evidence of unconscious implicit race bias among physicians, its disassociation from conscious explicit bias, and ultimately its predictive values. So as physicians, like I said, as physicians' pro-white implicit bias increased, so did their likelihood of treating white patients and not treating black patients with the thrombolysis. So there are obviously limitations to this study. The sample size was small, so initially there was 776 participants, but only 220 participants met inclusion criteria. The residence physicians located among these 4 centers in Boston and Atlanta may have differing protocols for other medical centers regarding the typical management of thrombolysis care and how frequently it's used, and also these were all residents. So maybe if it was physicians with greater experiences, then the statistical significant data might have been different. And then these were computerized patient vignettes, so you can't really measure or examine the actual physician-patient relationship. Another thing I found interesting about this study is they asked the participants, do you agree or disagree with the below statement? And subconscious biases about patients based on their race may affect the way I make decisions about their care without my realizing it. So before completing the IAT, 60.5% of physicians agreed or strongly agreed with this statement, and then after completing the IAT, 71.6 physicians agreed or strongly agreed with this statement. And they also noted that 74.8% felt like taking the IATs is a worthwhile experience for physicians, and 76.1% felt that learning more about unconscious biases could improve their care of their patients. So let's kind of look at it a different way from a conceptual model. So let's say we have a white male clinician whose implicit bias has been triggered by a visit with an elderly African-American patient who is on antihypertensive medications but whose blood pressure is uncontrolled. So without realizing it, that physician has become unduly influenced by his implicit bias and may perceive the patient as uncooperative and unlikely to adhere to a more intensive drug regimen. The clinician may also erroneously remember that the patient can afford the pharmacy, therefore entering judgments also into this encounter. Consequently, although the patient's hypertension is not under control, the clinician may decide to not intensify the therapy due to concerns about compliance. The clinician ultimately believes that he's made the best decision given the situation, unaware that his perceptions may have been distorted by implicit bias. Also shown in this model is the possibility that in addition to affecting clinical decisions directly, implicit bias may also affect the treatment through its effects on interpersonal communication here between the patient and the clinician. A number of studies have shown that people with more implicit or ethnic racial bias have poor interpersonal interactions with minority individuals in very subtle ways. Such interactions in turn may contribute to a lack of trust and commitment on the patient's part, leading to poor compliance here and ultimately preventing us from getting to our goal of hypertension control here. It's also important to note that the patient also brings their own implicit bias into the counter and judgments as well, which further presents more obstacles to get to their ultimate mutual goal of, in this case, hypertension control. So I know we were talking a lot about adults, so let's look at the pediatric population. So in 2012, this study here was used identical case studies or vignettes to examine how pediatricians' implicit and explicit racial attitudes or beliefs affect treatment recommendations for 4 common pediatric conditions. So pain, urinary tract infections, attention deficit hyperactivity disorder, and asthma. So a little background, as we all know, asthma is the most common chronic pediatric illness with a prevalence of 10% in childhood. And as we know, based on the percentages here, based off the summary of health statistics for U.S. children in 2009, you can see that there's a high prevalence among African Americans or Black patients. Same with ADHD. It's also very prevalent, especially in male patients of the population. And then we also have urinary tract infections, which account for about 5 to 14% of all pediatric room visits annually. So this study used data collected from a single session online IAT survey of pediatricians from one department at a large urban research university consisting of faculty, residents, and fellows who practice in the primary care setting, ambulatory setting, and acute care setting. A total of 95 participants were selected, and of those 95, 65% were female, 59% were residents or fellows, and 82% were Caucasian. So they were also given computerized pediatric case vignettes designed for the 4 common pediatric conditions that pediatricians would likely encounter in their clinical practice. And once again, they also used questionnaires to measure explicit racial biases. So here are just some of the examples of the case vignettes. So the patients were male in the ADHD and pain vignettes and female in the UTI and asthma vignettes. Each vignette had 2 versions. One version of each case was of an African American patient and one version was of a Caucasian patient. Each participant randomly received 2 vignettes in which the patient was described as African American and 2 in which the patient was described as Caucasian, but never the same vignette with the both race variations. Each case vignette was purposely designed to contain some degree of clinical uncertainty, and then the treatment options were designed to represent best practice versus adequate or good enough care so that subtle differences in quality could be assessed. So here are kind of the results from this study. So as you can see, it's mainly with pain that we saw statistically significant data. For pain, participants with greater implicit pro-white bias were more likely to agree with prescribing painkillers for post-surgical pain for white patients, but more likely to disagree with prescribing it for African American patients. Now, as you can see from the other common conditions, results showed that there were no significant associations between implicit attitudes or beliefs regarding race and any of the treatment recommendations for UTI, ADHD, and asthma. So conclusions from this study show that pediatricians' unconscious race attitudes or stereotypes affected pain management in the pediatric population, and this is just an example of how understanding the implicit racial biases may help explain differential healthcare treatment in the pediatric population, at least in regards to pain management. So once again, this study had its limitations, so the sample size was small. Only 53% response rate for completing all measures of the survey. Female physicians and white physicians were overrepresented relative to the eligible sample, which makes the data not necessarily generalizable. And prior studies have also shown that female physicians hold less implicit bias than male physicians. And then once again, we had the computerized patient vignettes, so it's really hard to examine the actual physician-patient relationship and interactions. So those were just 2 topics in which they looked at implicit bias, but as you can see here, there's been various different articles looking at implicit bias, and while I was doing my research, I even came across TED Med talks on the subject as well that were very interesting. I do want to take a second to focus on one of these articles here. It was actually done by the Kaiser Permanente group. And so they were looking at communication and patient ratings of interpersonal care. And so I actually went to California and interviewed with Kaiser for one of my interviews this year. And I thought it was very interesting how technologically advanced they are. From the time these patients check in to the time they check out, everything's on iPad, everything's computerized. So at the end of the visit, they do a patient evaluation or survey on the physician that they saw, and they're able to break it down into gender, race, age, socioeconomic status, etc. And so it was part of my interview. One of my tasks were to do kind of some role playing with a group of subspecialists, and so my scenario was I go into my boss's office, and she is doing a performance evaluation and pulls up these patient surveys. And it's showing that with the Hispanic or Latino population, my patient satisfaction or communication is persistently low. Why do I think that is, and how can I fix it? So I answered that question, and after I finished, one of the physicians that were a part of that group actually told me that was a real scenario that happened to him, and he had to explain why his communication scores with a certain population were so low, and they required him to fix it. So I feel like as technology advances, we have Yelp and social media and all these things where people are making these comments. I do think at some point, as physicians, our implicit bias and those sort of subtle interactions will kind of have to start holding some value, and we might have to start making changes because it will affect our performance with our patients. So I just have a short video that talks about some of the stuff that we have discussed thus far.
So in healthcare, bias comes in various forms. And I would say there's three primary ways that we could actually track bias. One, of course, is in interpersonal interactions, let's say between a patient and a provider. So the unconscious ways that we may have associate certain groups, certain gender identity, people with certain gender identities, people from certain racial or ethnic backgrounds, manifests in the diagnoses we're making, the interactions we're making with the patients, as well as the warmth with which we're working with them, which impacts the amount of trust that they have in the providers themselves. How does that manifest? One of the major ways that's been studied and shown and reported over and over again is pain management. So patients with darker skin, African Americans, receive lower dosages of pain medication across the board, from infants to the elderly, for the same types of ailments they come to practitioners for, because of assumptions that are being made around addiction or their ability to actually be truthful around what they're experiencing. The second way bias really plays into all of this, particularly unconscious bias, is the internal dynamics of organizations, how employees and staff members communicate with one another, team collaboration, team dynamics, but as well as performance reviews around compensation, who gets to be promoted, who gets to be a leader of an organization, of a team, based on assumptions that we may have about those people, purely based on phenotype, their origins, whatever that may be. And the third way bias really plays out in healthcare, and this is quite well documented across the board, is its costs, wasted costs. So racial bias, just one particular identity that we're concentrating on, costs the U.S. economy, the healthcare system, $310 billion a year. And for me, I just want to think about what can we do with that money if we didn't have bias in the world.
I just thought that was a pretty short video, but it talked about and touched on a lot of the things we've talked about so far. I also want to look at it from a medical student perspective as well, because as physicians, we are also kind of molding the young minds of the next generation. And so this is actually from the AAMC diaries based on a student's encounter or experience. So I once spoke to a teenage girl living in an urban location who had a severe abdominal pains. Because she was a black teenager in an urban city, the doctors at the hospital assumed that she was either pregnant or had an STD. As a result, she had a number of gynecological exams over the course of 3 months. Meanwhile, her condition continued to worsen. After her mother asked to have her daughter seen by a gastroenterologist, she was correctly diagnosed with Crohn's disease. Because of numerous doctors' implicit biases about black female teenagers in urban cities, this patient spent 3 months suffering when she may have been diagnosed and relieved of her pain much earlier. The stereotypes these doctors held may have impeded her treatment. So as I was also doing research, I came across a lot of articles talking about how implicit bias can be discussed and addressed at the medical school level as well. I know when I went to UT Houston for medical school, we actually had a diversity lecture series, and one of the sessions that we have actually consisted of a group of minority physicians, different races, different sexual orientations, who came and just answered a lot of our questions about some of experiences that they had faced with patient interactions because of their minority status, or even amongst colleagues, and kind of gave advice to the next generation. I also remember I had in one of those lecture series, one of the physicians, she was a white female physician, and she asked us at the beginning of her talk, you know, why do we write the race or ethnicity when we're doing our HPI or giving case presentations or the assessment? Is it, so by saying this is a 16-year-old African-American female with abdominal pain versus saying this is a 16-year-old female with abdominal pain, does it make a huge difference? If they're mixed, what do you put there instead? And she just kind of touched on that sometimes by putting the race or ethnicity in that one-liner that we always do, it might lead to prejudgments prior to laying eyes on the patient. And then when you do lay eyes on the patient, aren't you going to know that what their race or ethnicity is right off the bat? So the question was it really necessary? She kind of left that up to us to decide, but I also, you know, that kind of just stuck with me as I went on as well. And then also medical schools are moving towards having kind of like small group sessions where they discuss implicit biases and some of the experience students have had thus far and how they can change it and not let it affect their clinical decision making in the future. So as we look to the future, some things definitely still need to be done. So I think we need to determine the degree of implicit bias with regard to the full range of social groups for which healthcare disparities exist. So most research out there really does look at black and white, but there's so much more than just black and white. You have age, gender, other ethnicities to look at, gender identity or sexual orientation, obesity, disability, mental illness, religious preferences, that I think all needs to be studied further so we can better quantify and look at how implicit bias is affecting medical care and clinical outcomes. Also, research on the patient's implicit bias and what they bring to the clinical counter based on the race or ethnicity of the physician, as well as if the physician has an accent, should be explored further as well. And then finally, we need to create and develop theory-based interventions to reduce the effects of implicit bias in healthcare and clinical decisions. And so this might also include just by getting this further research done, we can look at maybe actual physician-patient encounters and not just in vignettes to see how things might be changed. So the Institute for Healthcare Improvement has these IHI white papers on achieving health equity. So this is looking at it from an organizational standpoint. And it's important to remember that there can be organizational bias in place that can support or potentiate implicit bias. This actually could have its own grand rounds by itself, so it kind of exceeds the scope of what we're going to talk about today. But it's important to address implicit bias at all levels. So we're going to focus more so on the individual and how as we as medical professionals can address implicit bias and make some changes.
So bias by itself is an algorithm of the mind. So it's a complex set of emotions that have become attached to one another that then manifest into the way we perceive, reason, remember certain things, certain incidents, and make decisions. And that's what bias is. Now there's two forms of, big picture, two forms of bias. One is conscious bias or explicit bias, something we know as, racism or sexism or anti-Semitism or even transphobia, Islamophobia. These are forms of bias where people hold conscious, explicit beliefs about other groups, whatever that group may be, whether it's women or people with a certain gender identity or sexual orientation or ethnic group. But then there's a form of bias called unconscious bias or implicit bias. And what unconscious bias is basically ingrained habits of thought that lead to errors in how we perceive, reason, remember, and make decisions. And over the last 20 to 30 years, leading research from across disciplines, from criminology to health policy to marketing and advertising research, has really shown that unconscious bias is one of the leading causes of inequity in our country. First of all, knowing one's bias is really important. So for the vast majority of Americans, we won't say that we're biased, because we're not, actually. Consciously speaking, we believe in the three pillars of our democracy: life, liberty, and the pursuit of happiness for all people, regardless of our color, regardless of our gender, our sexual orientation, our religious beliefs, because those are deeply ingrained values we hold. But when I talk about bias, it's really about unconscious bias or implicit bias. And that's, again, not our fault that we have it, but in the age we're living in, we have all the tools to hack it, to break that bias. So it is something that we have to be responsible for. So the first thing that health practitioners, providers can do is know their implicit bias. So log on to Project Implicit and take a free test that takes 2 minutes to do, but really see where on the spectrum do you fall with respect to racial bias or gender bias or sexual orientation bias or age bias. So we become aware of, wow, this is how my brain is primed to see people, and this is how I'm making split-second decisions. That's the first thing, right? The second thing is really looking around our friends and family circles. Unfortunately, we're still living in an economy where less than 9% of our physicians and less than 15% of our physicians and our nurses and nurse practitioners are of color. And when I say of color, really primarily African American, Latino, and Native American. So these are really small percentages. For a country that's over a third African American, under 10% of those practitioners that are providing to those communities, that may come from those communities, may understand the experiences of those communities, are not from those communities. This doesn't mean that we can't provide equitable care to those communities. Of course we can. We have that potential. But we need to hack bias to do that. And one of the primary ways of hacking bias is social contact. So look around and do one thing. Notice who are our intimate friends. What's their background? What ethnic background do they come from? What's their histories? And just literally do that self-reflection. You can even write it down, map it out. So you know in your own inventory that, oh my gosh, most of my friends are black. Most of my friends are white. Most of my friends are Indian or Asian or Muslim, whatever they may be, whatever the identity is. They're gay or straight. Because that way you know that that's the community you're living in. And that's the community you're relying on to carry on. So taking that inventory check. And third, invite the other to dinner. So literally seek out, if you feel like you don't have a diverse group of friends, people that you really can share something with, make one. And how do you make one? Starting with a coffee or a lunch. But in that coffee or lunch, ask them 2 questions. And this is really important. Ask them the following 2 questions. And tell them your own answers to these questions. What breaks your heart? What makes you come alive? and see where that goes.
So let's kind of touch base on that. And as I was doing the research as well, it kind of took me back, some of the articles I was reading, back to this oath that we took, which seems like so long ago. But I do want to just kind of point out two statements in this Hippocratic oath. I remember that there is an art to medicine as well as a science, and that warmth, sympathy, and understanding may outweigh the surgeon's knife or the chemist's drug. I will remember that I do not treat a fever chart, a cancerous growth, but a sick human being whose illness may affect the person's family and economic status. My responsibility includes these related problems if I am to care adequately for the sick. So we all took this vow to treat all patients as respected individuals, and I think it's important for us as physicians to pay attention and to be sensitive to our patients' socioeconomic status, gender, sexual orientation, ethnicity, in order to provide the quality care that we took an oath to provide. So also in one of the articles, it kind of talked about bias mitigating strategies, which we touched on a little in the video, and we'll just focus on the one here for clinicians. But sometimes, you get those gut reactions with specific individuals or groups or encounters that you may have with a patient. So kind of realizing that you might have this and kind of explore it further. Sometimes we try to suppress some of these awkward thoughts or situations, but really we should kind of reappraise them and acknowledge them in order to help realize this implicit bias and to move forward. You can obviously consider the situation from the patient's perspective, and then also kind of, like you said, exposing yourself to other groups and scenarios as well. All these sound like pretty simple suggestions, but with all the various stressors in life and work, sometimes there's little time for reflection, and even the most good intention of thoughts are hard to fulfill because we have implicit bias going on in these high stress environments, and so oftentimes it goes unchecked and we don't pay attention to it. And just kind of a little food for thought. I kind of had a Michael Jackson moment as I read some of these quotes in the article, but the presence of implicit bias among clinicians further suggests that it could play a role in healthcare disparities just as it plays a role in differential outcomes elsewhere in society. If one thinks of implicit bias in psychological terms as an automatic cue response association, then one might see that changing the cue is likely to be more effective than trying to will the response to change. And what does that mean, changing the cue? It means exposing yourself to scenarios and experiences outside of your comfort zone or interacting with people outside of your social group. So here, when we go to like Teen Mom or Teen Court or some of the other, the Cato Center, things that maybe when we were growing up, drug abuse, teen pregnancy, domestic abuse that we weren't exposed to, by exposing ourselves to these different scenarios, we can have a new reference point to start at, than rather from at kind of ground zero. So then when you come across these scenarios, especially in the clinical situation, by being exposed to it, you can kind of have a different response than if you were not to be exposed to it at all. So these are the references I used for this presentation, and I'll be happy to answer any questions. And this here is just if you're interested in doing an IAT, you have the project Implicit that was mentioned in the video, but also the Kirwan Institute for the Study of Race and Ethnicity at The Ohio State University actually teamed up with MTV in 2005 to start a movement of bias awareness and a bias cleanse. So they also have some IATs that might require a little less information on gender, race, and sexual orientation that I think is kind of worthwhile to take. I obviously took these when I was preparing for this presentation, and I was very surprised to find that I have a moderate gender bias. I think males are more associated with math and science, and females are associated more with liberal arts. If you know me, I don't explicitly believe that at all. I think girls can run the world and do whatever they want. But then I took a second and reflected and realized just last month when I was on my HEMONC rotation with Dr. Giroudi, I went and saw one of his patients who was about to graduate and go off to college, and she told me she wanted to be a biomedical engineer. And one, I was like kind of surprised, You don't really hear that every day. And two, I said, yeah, that has, a lot of math in it. And I just implicitly made this association without even realizing it. So I definitely think it's worthwhile taking a look at. But that's all I have for y'all. I'll be happy to answer any questions.
Well, that was a very well-researched and thorough review, so thank you very much. Questions? Comments? So do you think the test from the IHI group is something that everybody ought to do?
I definitely think so. I promise you it takes like 2 minutes. For each one of these tests, it takes 2 minutes, and I think you'll be pleasantly surprised or not so pleasantly surprised to see what your biases that you hold implicitly are. And I'll be happy to help anyone access it if they need help doing so.
Maybe Dr. Cooper would like to put that in the beginning of all the residency as we start our residence out. How about that?
With the studies you looked up, was there any difference in results as opposed to different locations if they did them in different spots? Like, for example, if they did a study on implicit bias on the East Coast as opposed to West Coast, South, North?
So the participants, the ethnicities among the participants kind of changed when you kind of went from different locations, and it actually showed among pediatricians overall there is a lower implicit bias, but when you start looking at East Coast, West Coast, places that have a higher majority of minority physicians, it did show that the implicit bias was somewhat less when you had a study that had a greater population or participants who were minority status versus Caucasian status.
When Nicole, when I was looking over this presentation with her, we had a discussion about that hypertension scenario. And I think a lot of times when residents go into a room, and I think we were even talking about when I was an intern here, I was the only African American intern in the whole hospital, like the whole hospital in 2000. So, I'm used to always being the only one. So a lot of times when we interact with patients, there's been so much bias against them in the healthcare field that a lot of times the patients are really cold or difficult to talk to, or you ask them what's the problem and they'll say just look in the chart, or if you try to ask them about feeding regimens or who's in the home, they can be really sensitive to that because they've been fighting biases their whole lives. So I try to tell the residents when we go in the rooms or you interact with patients, I always ask, like, where do you go to school, or what's your favorite subject, just so people understand that, or I have a daughter named Kennedy and my daughter's in kindergarten, because sometimes you have to meet people where they are for them to kind of break the mold and talk to you. So I just encourage you guys to really kind of take the test and listen to some of the things, because it's very true. I see it every day when I go in patients' rooms, or when patients ask me questions. They've been in clinics, different resident clinics, and they'll say, well, can you see me? And I'm like, no, I'm a Friday afternoon. Nobody wants to come Friday afternoon. Like, we'll come. Just because you build a relationship with people, because they feel like you understand what their story is. And I think it's very important as you move out into the world, regardless of where you practice or what you do, that you kind of take the time, like she said, to find out what people's stories are, because it really makes a difference when you take care of them, because they see that you care, not necessarily about the fracture or the pneumonia, but you care about how it impacts their families and, like, moving forward, what they can do to not be in the hospital the next time. I think that's really important.
When you're running across the instructions, whether it's community situations, in clinics or systems where they try to force a lack of implicit or explicit bias in treatment protocols or treatment mechanisms,
kind of actual implicit bias kind of be forced into a situation. I didn't see it in the medical field, more so as I saw it in universities and institutions where they're kind of forcing like lecture series and small groups on implicit bias at the medical level. But at a hospital or clinic organizational level, I didn't come across that yet. But then those IHA white papers that I mentioned previously, they are kind of starting to be distributed more to at the organizational level, but I haven't seen kind of results from that just yet.
So I think, oh yes.
Just a comment. Love this topic. You did very good, and I also think medicine needs to hear this as well.
So I think, we always talk about it's really important that you establish the therapeutic relationship with the patient. So it's understanding where the patient is, it's understanding what the patient needs, and it's understanding how to get the patient to be committed to do what's necessary for their own health. And the way to do that is by really relating to the patient. So I think everybody leaving here today needs to understand that there is potential for this implicit bias in everything that we do. And so you need to pay attention to that and use that information as you work with individual patients, because they're all going to require a different approach for you to develop the therapeutic relationship to be successful. This is one impediment to making that happen. So Nicole, thank you. This was a really nice way to do it. So thank you. All right.